And then I want to introduce my school a little bit. So right now I'm an assistant professor working at Penn Dental Medicine. And as you can see here is where the university based. So this is in our university, and this is Philadelphia. We have our city hall here. And this is these are our class residents, and we really have a lot of fun in the clinic as well, not just learning the dentistry. And this is the front door of our dental school. And in addition, this year, one big thing about Philadelphia was that we won the Super Bowl. So that is the American Super Bowl, a big thing for us. So I went to the parade. And this is our pre-doctoral clinic. And for the class right now, our D2 class, we have 168 students. And then for international students, we have 30 students. So our class size is pretty big. And this is our front door. And if you ask me, do you feel a lot of differences between students across different countries? Honestly, I don't feel that much. But one important thing, like what I find our students compared to when I was a student, is that I feel nowadays we have so much more resources, including online, including you can find a good mentor like easily. Like many people here, I noticed that you want to become an oral surgeon, then find the right mentor that will guide you through this. Because I really think knowledge should be shared and exchanged, so that's how we can push our specialty forward. So first I want to start with this. Do you remember when you are in the fixed class lab? The first project you might have to do is taking an ocular impression, and then from there you will learn how to make a crown gradually. So here you have your upper and lower arch, and here is a simple articulator that you will have. And the first thing you will do is you will check your occlusion using this articulating paper. And why we do that was because before you make the crown and after you make the crown, the occlusion should stay the same. So the first thing I ever did was I checked the occlusion and to see where are my cuts to fossa contact, especially for the posterior, because I'm making the crown for 2026. And remember, this is on typodome, so there's no PDL or any other issues. And then from there, you learn how to do the tooth preparation. And then I did the tooth preparation, taking the final impression, pour the cast. And I don't know if we do facial here, but United States, we try to do as little facial as possible now. And then we pour the cast. And how do we mount the maxillary and mandibular cast? It really depends. It depends on how many occlusal contact that you have. Are your cast stable enough? And after that, you will do a ditch and die to get this master cast, mounting on the articulator, and from there you do a diagnosing wax up. And after you do the wax up, you duplicate this and send to the furnace, and then you got your gold crown. So I did all of this by myself, but I still find that there's a hyperocclusion. So why is that? So first you have to think about how many materials that we use to get here. We utilize the PVS impression, we pour the cast, we use a mounting stone to mount our cast, we use a faithful, everything can incorporate the accuracy. And not just that, this is on dental form, but what about you are on your natural teeth? And how do we get that in accuracy? I think that is something to think about. Because in our natural teeth, when you bite light or when you bite strong, it might have a different consequence. And in real patients, we usually take bite with bite registrations, like PVS if needed. So imagine PVS also has a thickness And now if we have the digital technology, would that be a game changer? I think that's something we have to see. Because if you take the bite digitally, you can not only see where the contact is gonna be, but also you can see the intensity of your contact. And then if you want to make a dental implant, do dental implants perform the same as natural tooth? It might be not. And also, if you have one dental implant you want to perform, opposing its natural tooth, versus if you have one single dental implant, opposing one single dental implant, would they have the similar occlusion? And when you take a bite, how do you ask your patients to bite down? How much force they should apply? I think those are the questions we really have to think about. So I think this morning we briefly went through this, but this really goes back to what's the difference between the natural teeth and dental implant. So if you look at here, this side represents the natural tooth, and the right side represents the dental implants. And this is the histology of the tooth versus the dental implants. So first thing you can notice here is we have the sharpest fiber in our natural teeth, and the direction of the sharpest fibers are perpendicular to the root. So this will hold your tooth by the PDL. And on the other hand, our dental implants, you can appreciate that the fibers here are parallel to the dental implants. And remember, the definition of osseointegration is direct bone to implant contact. So here we don't have a cushion in between. So what will happen next is, okay, so inside of our natural tooth, here we have the PDL. In our PDL, we have the mechanoreceptors receptors that will give our central nervous system about like how much force you are biting. And however, in our dental implants, we don't have such a thing to serve as a force resolving like agent in between. So what will happen next is when you under different types of the forces and direction, how will our tooth and dental implants move? So if you first think about, we can divide the force into the vertical force and the horizontal force. So if you under the vertical force, ideally your tooth will have the apical movement. And in tooth, the apical movement is about 25 to 100 microns. And your dental implant is much less. It's only 3 to 5 microns. And same pattern for the lateral movement. For the tooth is 56 to 150 microns. And for dental implant is 10 to 50 microns. So it's also much less compared to dental implant. And another interesting thing to see is where the fulcrum is gonna be. So if you have a vertical force that applies to the dental implant, because we have the PDL, so we have the ability to transfer the force all the way down to the apical third. And apical third become our fulcrum line, fulcrum. And for dental implants, it's not the case because we have a direct bone-to-implant contact. So where the stress is gonna be the cervical third. So this will be at the crest of bone. And another thing to think about is how will the tooth move? So initially, because we have the PDL here, so when the tooth is under force, initially it will be non-linear, and after a certain time, it will become the secondary phase. We'll expect the elastic deformation similar as the bone movement. And for a dental implant, because we don't have the PDL, so we will not have that initial phase. It will become only elastic phase only. So understanding this difference, then how do we apply it clinically? Next. So let's think about what would be the issue if you have a dental implant not having the PDL. So if you have the force here, and you put the articulating paper in between upper and lower, then what happens is we will have different amount of the compression. So our tooth will have more compression compared to our dental implant. So whenever you bite, it seems like the implant will not move as much as the dental implant. And also, as I said earlier, implant we don't have the mechanical receptor. So the high threshold of the tactile sensation will become an issue because as a patient, the patient will not know when to stop to bite. So this becomes one of the interesting fields that we have been investigating. So how do we know how much difference that will have? And there have been evidence showing that occlusal contacts on implant-supported single crowns were about 10 to 30 microns, lighter than on adjacent teeth in maximum in the cuspal position. So the left photograph here shows if you utilize the 30 microns articulating paper, you will not see any occlusal contact when you deliver your implant supported prosthesis. However, if it's on the right side, if you use 100 microns and ask the patient to bite down, you will appreciate that the implant becomes the occlusal contacts. And then talking about occlusal force and bone mechanics. So for occlusal force, I think it can be categorized into these four important categories. First is what's your magnitude of the force? How much can patient bite down? And second thing is the duration. If you have a Bruxer patient, maybe the duration of the time will much increase compared to a normal patient. And the third thing is the distribution. How many implants do you have? And how do they distribute the force? How big is your occlusal table? That might all be the issue. And here is the direction. So a force can be divided into the vertical sector and horizontal sector. So the vertical sector, we call it the axial force, and horizontal sectors, we call it the lateral force. So when you have a force that comes angulated, what will happen is the implant itself will kind of rotate across the open line. It will create a bending moment, although bone and implant is also integrated. And what will happen is, here you will appreciate the compressive force on the contralateral side. But the same side, you will appreciate the tensile and shear strength. And tensile and shear strength, bone is less like resistant to that. Bone is, especially cortical bone, is better with the compressive strength. So you want to know how do we manage these forces. And another important thing to think about is posterior teeth, how do we align? It's usually cut to fossa, but anterior teeth, they are inclines to incline because for aesthetic reason. And if you see the anterior teeth, usually where you place the implants, we place on the palatal side. So compared to the implant analog, here you can see the incisal edge is much more buccal compared to implant analog. So that will create a horizontal force. And another interesting study that done by Dr. Mish is, here we have a 100 Newton angulated force right at the 12th degree. What he found was if you do mathematics, if you have a 12 degree angle force increase, then you will have the force increased by 18.6% of your dental implant system. So do we want any lateral force on dental implants or not? That becomes a debate for years. And let's think about how do our body react to overloading. So first, here is my patient. You can appreciate that here we have tooth number 8, which is a natural tooth. Tooth number 9 is implant crown, and you can see that here we have some porcelain fracture. And in addition to that, we are missing the first premolar here, and then the lateral incisor and canine, they are edge to edge position. And here we have the implant school. So when she came to me, she had not only the porcine fracture, but also we noticed the screw loosening. So let's think about how do our natural teeth respond. Because our natural teeth, we have the PDO, we have the mechanical receptor. What our body will do is we will have a defense system. So our body will have a PDO signaling, increasing the mobility from the trauma from occlusion. And sometimes you will notice that we'll have the wear with the adjacent teeth. But for our dental implants, it's another story because our dental implants, the feedback from biting force is not as strong as the natural teeth. So it's not easy for the patient to detect if he or she has the overloading. And think about how our implant crown and implant system are formed. So here we have the implant, and also we have the prosthetic screw or abutment screw, and then we have the crown. So where is the weakest point? The weakest point is usually at your screw. So that's why we'll see in the clinic, you will see the screw loosening or fracture, because that's the weakest point. And for screw, we can have prosthetic screw or abutment screw. It's usually the prosthetic screw that will fracture more because of the diameter. And from bottom to the dental implants to the top, we can have all kinds of complications. We will have the abdominal processes fracture and even crestal bone resorption because the implant itself is under a lot of forces. And in severe cases, you can even observe the implant fracture. And sometimes not just that, implant, the natural tooth adjacent to the implant will even have the open proximal contact. That is an interesting observation that we have. And let's look at this case. So this case is from Mish's textbook. So you can appreciate that upper we restore with the dental implant bridge. And what we had here was the implant abutment screw fracture on the right side. And for the left side, we have the dental implant fracture. So this is such a disaster. So why would we have that? That becomes like quite an issue. Is it because of the occlusal force and we don't have good posterior support, or we don't have good oral hygiene? And there have been debate about if overloading will associated with the marginal bone loss or periimplantitis. And I have checked so many articles, and the evidence doesn't really support it. We do see some bone loss, but it's really hard to have a standardized clinical study, because if your patient has overloading, what would you do? I think most of the people, they would do occlusal adjustment. They will not let the people to have the hyperocclusion for a long time. So most of the study, if you see, is final elemental analysis or radiograph study. And the incidence of that was really low as well. And let's look at another case. So this case, the patient came in and told me she had dental implant fabricated 7 to 8 years ago. You can appreciate that the gum is really inflamed, and we have a lot of inflammation around the tooth or around the implants. And patient also noticed that her bite gets really worse. And would you say this is a periimplantitis, or would you say this is overloading? So I think if we all agree, I would say this is more like uncontrolled periodontitis and also the periimplantitis, because you can clearly see we don't have bone here. And also we don't have good posterior support, and the oral hygiene is really bad. But I showed this case to one of the parallel pros faculty in our university. And I think he brought up an interesting point is, if you look at lower teeth, lower anterior teeth, where the force is directed is usually axial. But for upper, because of the inclination towards the buccal side, so it's usually having the off-axis loading. So in this kind of case, he will consider this as a periimplantitis case compromised by overloading. And let's think about what are some overloading risk factors for implant prosthesis. And that goes back to what's your magnitude and duration, distribution, and direction. So one of the most prominent overloading risk factor is the cantilever. And then the parafunctional habit, premature contour, and also you have to consider about the bone quality as well. And not just bone quality. Imagine that our mandible will also flex when you do opening or when you do lateral movement. So it gets everything very complicated. And let's talk about cantilever. If you look at the cantilever, the magnitude of the load will become proportional to the length of the cantilever. So if you see here, if you have 2 implants and you want to do a 3 unit, you want to do it on the mesial rather than distal. The reason behind that was because the distal cantilever will
thì ở dạng cầu với thì các bạn sẽ thấy rằng cái độ lớn của lực nó sẽ tỷ lệ tác động bên implant nó sẽ tỷ lệ thuận với chiều dài của cái đơn vị với. Và ngay cả đối với những trường hợp phục hồi một răng bằng một implant thì các bạn cũng không muốn cái phục hình cái phục hồi cuối cùng cái trục trên implant mà có dạng với như kia. Và không chỉ như thế.
Let's see here we have a maxillary implant bridge. So you can appreciate the screw hole is near the lingual side.
Trong trường hợp này các bạn sẽ thấy rằng là cái lỗ mang vít mà bạn phục hình thì mà được đặt lệch về phía mũi trong. Và như vậy thì các bạn sẽ thấy rằng độ rộng của từ mũi ngoài đến lỗ vít và từ lỗ vít đến mũi trong nó sẽ có sự bất tương xứng và nó sẽ gây ra cái lực lên cái cantilever, mà cantilever ở đây chính là cái khoảng cách giữa mũi ngoài và vít.
And the next thing that we have been talking about is if the bruxism is associated with the implant complication. So what does the bruxism do is first, it increases the load to the implants, and second thing is how long is the duration of your occlusal contact. It's usually longer. Remember, in our human body, how much time do we have for tooth contact for the whole day? Within 24 hours, actually we only have 15.5 minutes contact according to Zal's textbook. So actually, if you have the power function habit, it will increase the time and also the
nhau trong một ngày của bệnh nhân nghiến răng là tầm 25 phút.
And so people saying that because of the duration and also the magnitude of the force, you will experience some marginal bone loss. And there have been some evidence showing that. But is the bone loss going to cause the implant failure? I don't think so, because there's only one study that really shows the connection between this. Because once you place a dental implant is already also integrated. They are not that easy to fail because of the force. So let's think about what will be your ideal occlusal scheme for dental implants. How do you design that? So let's think about this. So now you have your 2, 4, 6 single implant on the molar, and you design everything. You want to place a dental implant. Not only that, you have to think about the buccolingual bone, but also you want to think about what's the offset of your crown. And if you look at your crown, we can decide the occlusal table with buccolingually how much that we need to have. And a general idea is we need to have 30 to 40% reduction in the width of occlusal tables in molar. And the next thing is the cusp angle. If you have a really steep cusp angle, what will happen is you'll have a lot of lateral forces. So the general idea is your cusp angles should be shallow as possible. And then the third thing is the centric contact area. And if you want to have a good centric contact for your dental implants, because you will expect some movement because of the difference between tooth and implants. So usually our idea is you want to limit your occlusal contact to the central fossa and have a wide centric, about 1 to 1.5 millimeters, so you can give the space for the contact. And then this is the concept proposed by Dr. Carl Misch in 1994. It's called the implant protective occlusion. So what did he talk about? He talked about that for posterior teeth, you want to have bilateral stability in centric contact and try to get them as equal as possible and free them in centric and try to avoid any interference from your CR to MIP. And you want to direct your force axial if possible, and have flat contacts and reduce cusp inclines. And here we've got the concept of the narrow occlusal table, about 30 to 40% reduction for molars. In addition, you don't want any interference because that will include any lateral forces. And you want to have anterior guidance to help to disclude your posterior teeth as much as possible. And in his concept, we need to establish the mutually protective occlusion and good function if you have a compromised canine. And for dentures, we still kind of follow the natural teeth concept. We want to have balanced occlusion for dentures. So let's think about what has been changed since 1994. And first thing I want to mention is let's think about which factor is more important. Is it occlusal table width or is it the cusp inclination? So this study, I found it quite interesting because what they did was they fabricated 3-unit bridge with different designs on dental implants. So these two are dental implants, and the middle part is a pound tape. So group A, they have a narrow occlusal surface, but with a steep cusp. The second group, they have the cusp with steep inclination of the slope. And then the third group, they have the flat inclination of the slope, as you can see here. And what they did was they test the different textures of the food. So this is a gummy bird, this is considered as the soft food. And this is the bread, this is considered as the hard food. So let's see what will be the consequence. So what they found was for axial forces, it's actually not that different. If you look at the gummy birds or bread, there's not significant statistical significance between the groups. But when you have the lateral force, you will have the bending movement. What they found was you will see a significant difference between the narrow occlusal surface and the other groups. So that means that if you have a narrow occlusal forces, that can more effectively decrease your occlusal load compared to having a different cusp inclination. So occlusal table is more important than the cusp inclination, with both the hard and soft tooth texture. And another important concept I want to bring up is for Dr. Misch, when he talked about dental implants in the anterior region, he always wants to place dental implants in canine. And he thinks if you want to restore 6 anterior teeth, 2 of them should be in the canine position. And what's the reason behind that was because canine usually take a lot of force, and also is at the corner between your anterior tooth and posterior tooth. Canine is expected to have a lot of lateral forces as well. And then he thinks we should spring the implants if possible, because that will help to share the lateral occlusal force. And then for anterior teeth, as I said earlier, anterior implants, they are inclined to implants because we will need the overjet and overbite. So how shallow should we set up the teeth when we have the dental implant? That becomes a debate. But the general idea is we don't want our overbite to be more than 4 millimeters. because if it's more than 4 millimeter, it will disocclude the implants a lot, and that will cause a lot of the lateral forces. And another study, they found that if you have every 10-degree change in the angulation, there is a 30% differences in load. So how do we design our dental implants occlusion? And what did we do in the past? Let's think about natural teeth and denture. So if you are doing a full bounce rehabilitation, you have the full control to establish your occlusion. Posterior teeth, you want to have bilateral stable contact to support your anterior teeth. And you want your anterior teeth to not in contact when in central occlusion. But during protrusion, you want your anterior teeth to provide the anterior guidance and disocclude all the posterior teeth. And also, we can consider canine guidance if canine is strong enough. And also have the concept of the groove function, unilateral balance occlusion. And in dentures, we have the concepts of lateral balance occlusion and lingualized occlusion. So what did we get for implant prosthesis? And honestly, I have been searching for data to see what have been improved since these 20 years. And nothing much has changed, unfortunately. But the idea in general is because changes in occlusion can easily be adopted by our human body. Believe it or not, that our human body, we have the neurophysiological mechanism that can actually adapt to the occlusion that we design. But to say that, we still have to design properly. And the general idea is that you want to plan for the weakest arch. So let's see what it means. So here are different scenarios that you may run into. So if you have complete dentures against overdentures, you can treat it like just a complete denture and get the bilateral balance occlusion or lingualized occlusion. I like to design as a lingualized occlusion because it can reduce any forces during the lateral movement. So you set up your teeth, upper lingual cusp against the central fossa, but you don't have any contact on the buccal cusp. So that's the concept of the lingualized occlusion. And same concept can be applied to overdenture versus overdenture. And then if you have the overdenture on the maxilla against the natural teeth with bridge, you really have to respect your natural teeth. So sometimes you will run into the situations you cannot get bilateral lingualized occlusion, then it's fine to go with the groove function. And then as you get more and more dental implants, that also means you are losing more teeth. So if it becomes the fixed option, you can design it as a mutually protective occlusion, or you can design it still with the lingualized occlusion. And then let's look at what are some posterior fixed implant supported restoration that we should have in mind. Again, like axial loading, you want to have your angulation to be less than 30 degrees to reduce the lateral force. And then you want to provide your prosthesis with point-centric or freedom-centric contact. That is 1 to 1.5 millimeter. So give the central contact a little bit of the freedom during the movement. And there should be no occlusal working or non-working or protrusive interference if possible. And for anterior teeth, I think it applies the exact same concept. But the thing is, you have to consider the overbite and overjet. Because anterior teeth, usually your upper teeth are buccal compared to the lower teeth. So you want to flatten and reduce any protrusive and working guidance. And for complete arch fixed implant prosthesis, it depends on how many arches do you do. If you do one arch, you can try to establish with groove function or lingualized occlusion depending on your opposing arch. But if you do the complete arch, both upper and lower as a fixed processes, now you have the full control. So you can design it as a mutually protected occlusion. So again, the concept is posterior, you want to have good bilateral and stable central stop. But for anterior teeth, you don't want to have any contact. And during the protrusive movement, you want to have your anterior teeth guide your posterior teeth. So posterior teeth should have no contact. So this is exactly what mutually protected occlusion here means. So you want to have posterior teeth to support the anterior teeth, relieve any contact in the anterior region, and then have the posterior contact. And during the protrusion and lateral movement, depends on what teeth that you have. For example, you can appreciate that right side, our natural teeth, the premolars, they are guiding with each other. So here we'll have the groove function. And the other side, because we design the processes here, it will disocclude all the posterior teeth. So it's fine to have the canine guidance. So I feel like designing occlusion with both natural teeth and implants, you actually have a lot of control included. So here I want to share a case that we did during the residency. And this case, patient actually had been with us for 7 years. So there must be a reason behind that. So if you appreciate here, this patient, she wants to continue her dental treatment. She has some issues with her breast cancer, and then she came back. And you can appreciate that here. All the uppers are provisional processes. And all except the anterior teeth, they are all in temporary processes. And one thing if you notice here, this is a temporary cylinder, so 3-unit bridge on both top and bottom. And also on the right side, 3-unit bridge, top and bottom. But there's a gap, so you can appreciate that the occlusion is not the best in this patient. And if you look at the X-ray, these implants have been placed on the posterior, and we connected with a temporary cylinder. And anterior teeth, you can appreciate that here we have multiple root canal treated teeth with the core material and cascos and core. And after we discuss with the patient, you can calculate how many implants that she already had for the top. She already have 3 and 5. In total, 5 implants for the top. So she was asking us, can we convert it to completely implant supportive processes? So we agreed with her, and we decided to move on the case. Sorry, 1 second. So this is what patients look. So if you appreciate here, after we remove all the top temporary processes, these are the anterior teeth condition. The gum is quite inflamed. The implants are there with the healing abutment, but the angulation seems a little bit off. It's quite buccal side. And in addition to that, we have a combination of the tissue level implants and then the bone level implants. And same thing for the bottom. We have the 2 bone level implants, and we also have a combination of the natural tooth as well. So how do we start this? So I think I want to share with you, this is one of my co-residents. He is the smartest person I have ever met in my life. So his name is Alex Jelicic. He is actually the founder of the Overjet company. And he graduated from MIT engineering, and then he did the dental school and cross-residency at Harvard. So back then, what he really thinks is, it doesn't make sense for us to go back and do the diagnostic wax out again, because that will take a lot of work. If you want to do the analog workflow, you have to take impression, and then you have to do the wax out. And it's not easy to establish the good vertical dimension and also a nice wax out from the beginning. So what he did was, he was thinking about, can we do the cross mounting digitally? So the first thing, how we do the digital cross mounting. So first we need the scan, intraoral scan with both the upper and lower temporal crown. And then you remove the posterior implants and just scan the mandibular prep. So you can superimpose them together. And then you move on to remove the upper with the temp. Without the temp and against the mandibular temp. And eventually you will get the diagnostic model with the prep versus prep. So the benefits of that, think about how do we usually take the bite. We want to place the PVS bite registration material in between. But every time when you do that, you will incorporate the inaccuracy and also the thickness of your material. So back then we think it might be a good idea to try this. So that's what he did. We designed a new prosthesis that is a full arch because we are extracting the anterior teeth. So the first thing he did was he designed a full arch prosthesis and delivered to the patients before the implant surgery. They will have to do a lot of occlusal adjustment. I assisted him back then. Actually, not much, but you can see that occlusion during the lateral movement is not easy to reduce, even though we got centric contact very well. And then we move on to print our anterior dental implants. So here we decided to add 3 more implants. And the reasons behind that was because we want to establish the traditional crown and bridge type dental implants. So if you have a full arch FP1, then because you don't want the force to be concentrated in a single dental implant, so you want to section the arch into 3 segments. So that's what we did. And here came to a surgery day. In this case, we decided to do the guided surgery because that can help us to better control the direction and also precision. So again, here we utilize the peritone to carefully extract the teeth. And because we don't want to lose the soft tissue and also the buccal bone. And the 2 supportive guides on the posterior abutment can help us to precisely place the dental implants. And then here comes the implant surgery. So we place the guided implants and utilize the guide on the posterior, and we section the anterior implant bridge versus the posterior. And buccal bone, we always do the grafting as well. And then because you want to preserve as much as possible for your soft tissue, and also you want to have a good seal for your dental implant. So what we did was we did the customized helium abutment that is formed by the temporary cylinder that will match the exact size of this tooth extraction site. And in addition to that, because you don't want to apply any forces onto a dental implant, so that's why here we relieve a lot of the forces and let the patient go home. So that is the final result when I deliver the denture. When I deliver the fixed prosthesis. And then patient, unfortunately, she had a breast cancer recurrence again. But one thing that I have been thinking is about the cross-mounting accuracy, because nowadays we have the digital tool. So ideally, we don't need the thickness and the PVS bite registration material to help us to mount the cast. So ideally, digital mounting should be more accurate, but is that the case? And we have searched multiple articles, and usually what I found was if you have a posterior bridge versus anterior bridge, posterior bridge will have more accuracy compared to anterior. And think about mouth opening. When you open your mouth, is anterior opening versus posterior opening the same? Usually it's not. And ideally the ratio is about 1:2, but in real reality it's not like that. So they found that if you have a posterior inaccuracy, that will be around like 200 microns for the posterior. So what are the clinical takeaway here? I would say occlusion is still like quite controversial and very hard to understand. But when you design your prosthesis, you should really follow the biomechanical guidelines that can support your long-term outcome both biologically and aesthetically. And if you are doing a single implant crown, what you should design for your occlusal table is you want to have point-centric or freehand-centric to reduce any lateral movement and direct the force in the axial direction. And then try to design the narrow occlusal table as much as you can. You want your occlusal table to be slightly larger than your implant diameter, but you also don't want it to be too much because that will create the cantilever force. And then you want to have a shallow cusp. Try to avoid any lateral forces and eliminating any excursive contacts. And if possible, you want to avoid or minimum cantilevers because you don't have any implants to support that area. And if necessary, you want to have your cantilever on the mesial rather than distal. So that thing we have to think about is how intraoral scan may change our practice. So as a practitioner, I really want our crown to be like perfect. Let's say after you take the impression, next time when you deliver the crown, you don't want to do any adjustment. But is that possible with a digital tool? I would say it's still not there yet. Because our body, we compress differently. Everyone has different compression in terms of the occlusal contact. And also, it's not easy to estimate how much occlusal forces that your patient will have when they bite down. So I think that causes the whole issue. And that concludes my presentation. And I really want to thank everyone here today for the BNU and for Operation Smile and Zoom. And this is my first time lecture internationally, so I really appreciate this opportunity.
Thank you very much. It's really Harvard level, Harvard Dental School level. Actually, 22 years before my first dental implant, my case I could observe from him, my really teacher, 20 years before, 3-eye dental implant, and I'm in implantologist implant department. I usually talk to my students that my departure is above is occlusion, lower is periodontology. I usually talk to my students that we have four basic department: occlusion, anatomy, material, and occlusion. So this is a very wonderful lecture for our students. It's a step-by-step collect all of the knowledge for all of them here. The key present is the hyperocclusion. So she follows the step-by-step, compare the natural dental and natural teeth and dental implant. Then the final is the basic case clinical. So as all of you see that she talk about biomechanical, we know that word is from Kanggis, right? So and some we have two abnormal dental implant. It is a biomechanic and